And in the meantime, I would like to introduce our next speaker, Dr. Trevor Hirschi, who started his anesthesiological training in Solothurn, but finished it at Inselspital Bern. Dr. Hirschi is part of our team. He's in the core team providing cardiac anesthesia for all procedures at our center.
Start with the case report, which we faced a couple of weeks ago. We had an admission of at our emergency room of a 20-year-old female. She was complaining about shortness of breath over the last 4 to 6 weeks, and she already suffered from dyspnea on exertion for 1 year. She had no history of embolic events and no medication except of oral contraception. When she admitted to us, she was really tachypneic and slightly cyanotic. She had some ankle edemas, and her jugular veins were really prominent. And what's not written here, they did a TEE where they saw like some cardial mass in the left atrium. So she was transferred actually as an urgent case to our operating theatre. The general anesthesia was actually uneventful, and when we did our TOE, it showed this image. Can't really show it nicely, but what we see is a huge mass here. It was 60 times 40 millimeters and was attached to the atrial septum and was prolapsing with every cycle. During diastole, it was prolapsing in the left ventricle, causing actually a functional mitral stenosis, a severe mitral stenosis. The mean pressure was around 11 millimeters of mercury. But the left ventricle itself and wall thickness and function was normal. Here I have some more pictures. Images, long axis view. Sorry, I can only show it this way. And here with the color flow. So what we saw is really a huge mass. And here a 3D image, the mass itself. And here we can see this functional mitral stenosis. We showed it all to the surgeon. The mitral leaflets itself, as much as we could see them, were actually normal. We didn't see any thickened leaflets and also no really relevant regurgitation. The annulus itself was a moderate dilation. We measured about 40 millimeters. The tricuspid valve itself was dilated as well, and it showed a severe tricuspid regurgitation. The estimated systolic pulmonary artery pressure was around 75 millimeters of mercury and was a severe pulmonary hypertension. Here the picture, I'll show it once again. So we showed all that to the surgeon, and what was done? It was a complete resection of the cardial mass from its attachment, and the defect was closed with a pericardial patch, and the tricuspid regurgitation was fixed with an annuloplasty, as shown here. That all went very nice. And here's the mass which they took out. As you see, it's huge. And the mitral leaflets itself, the surgeon also really carefully inspected it, saw nothing really abnormal. Everything was fine. He did a water test as well, and the valve was actually, didn't show any abnormality. The water test was normal. What did we do? We went to weaning from the bypass in the reperfusion phase. We saw here the ring. We had no really residual TR, and here as well. This picture doesn't work, sorry. But you have to just believe me that here there was also no residual ASD. But what we found was actually an unexpected mild to moderate regurgitation of the mitral valve. Some measurements actually were more a bit for mild, but some were more a bit moderate. It was just at the edge to moderate. So we showed this to the surgeon, and we weren't sure actually. Sorry, here are two more pictures. The annulus a bit dilated here. And here the measurements we did with the PISA. And now we were at the point, 20-year-old lady, what to do next? Should we go on a second run on cardiopulmonary bypass or not? And we had pros and contras, which we looked together. The pros were on one side, the aspect as the pros to go on a second run meant here. And the aspect of the MR jet was not only